sharing the experience of Mozambique in the development of DHIS2. And we'll be able also to hear that the Mozambique started in 2000 with the process of implementation of DHIS 1.4 first, and then went through several stages until it reached, or they started to adopt the DHIS, the version 2 of DHIS2 official, which is used at the moment with different programs. So I will invite Dr. Brana. She's heading the HMIS, I think 2 years now. This is the second year, but she has been, before going to the HMIS, she has been leading the logistics. And I think thanks to her, we are able, for example, to have some logistic data which is collected using other digital public goods to which they are integrated in DHIS2. Then I will invite Dr. Brana to sit here. And also we'll be having Dr. Amelia Dipuve. She's part of the EPI program. I think is a director or deputy director of the EPI program in Mozambique. At the moment, we are supposed to have also the director here, but they are started with the mass campaign, polio campaign that started this week. That's why we also selected this topic to be shared. How are they managing the campaign, the polio campaign using DHIS2? And also there are some other initiatives that came before polio. So I will invite Amelia to also sit here. And with the different, let's say, needs of integrating data, the malaria program also decided, because they were having also challenge with regard to data use, everything, and then the component of data that was in DHIS2 was initially was not enough. It was only collecting the number of people that were tested, treated, and then they decided also to integrate all the malaria component, including financial data. And then we created what they call malaria data repository. So Mariana da Silva is here to share with us the experience related to this initiative of developing a malaria data repository. Because we always have there will be maybe a need to have some translation here during the process. So I will invite Emilio Moss, who is leading the research unit at South DHIS2, also to come and sit in front. Yes. So to start, I think Dr. Brana will be the one starting the presentation, and then we'll conduct the whole process of implementation. I don't know if you are going to move the slides by yourself. Okay. Thank you.
Okay, and then just pass.
Almost.
Okay, good morning. I'll be starting the presentation of the health information systems in Mozambique. So, Mozambique, wait. Not moving. What's it? I should use the click. No, this was not working. Okay. So Mozambique Minister of Health adopted DHIS2 as the main platform and called SISMA. SISMA means Health Information System for Monitoring and Evaluation. So we will see how it was before the DHIS2 implementation and where we are coming from. So during the period between 2000 and 2004, Mozambique had many attempts and many platforms, electronic platforms, to improve the data management. Some of these were the SISPRO, SIM, DHIS2 version 1.2 to 1.4, and Módulo Básico. But all of these electronic systems, they were not match the expectations and the needs of the users. So we just took the lessons from that whole process and move to the next phase. So let's see how it was the initial implementation. So we had the metadata and all the data in module basic, and this was migrated to DHIS2 database. And the implementation approach switch from server spread across the districts and province to a centralized approach, a central server. And some programs and areas that were not included in the beginning of module basic, they had the opportunity now to be included in the new version of DHIS2 or SISMA. And the facilities were reporting, aggregated the facility level were reporting to the district aggregate information that was able to be visible. So we have this image just to illustrate what I was trying to explain. So at my left, it was module basic before. So you can see that it was a very complex collection process from manual to district, and then the district to province up to the central. But it took a lot of time to have this collection and to be able to see the information from the low levels. So now we have at my right the current scenario. You can have the collection from the health facilities, but that can be electronic or manual where there are no conditions. But once it's collected on DHIS2, you can see immediately at the central level. So if you have connectivity, it's directly centralized in the central server. So this is how we are current now, and we improved a lot the visibility of our data, and the health programs also increased a lot the performance of their indicators and promote use of data, of course. So the initial DHIS2 implementation brought a lot of advantages, like I was saying. So reduce the time taken to produce the reports. It was possible to access the data from all the facilities and for several periods, increase the quality of this data in terms of completeness, timeless. It was possible finally to have dashboards to do these monitoring evaluations performances, and also simplify the process to elaborate reports for the whole country. So to have a big picture of what was happening in all the health programs. So how was the process from moving from aggregate to individual? So the need of individual data came. We start to receive a lot of pressure from the health programs. They were satisfied with the aggregated data, but there was a challenge to move to the patient individual level data. So the inpatient and TB module, they were the first ones to be introduced in the tracker. Then we had the maternal neonatal mortality auditing and the maternity and birth modules. The success of these modules increased the demand, and now we are in the process of develop new modules for routine immunization, for cancer registration, and HIV recently after analysis evaluation that was done in a maturity of the DHIS2 system in Mozambique. So we still have a lot of challenge as a country, but this introduction of the individual models, it had a great impact because it was possible for the first time to have a report on the mortality and the causes of the mortality in our hospitals. So currently over 90% of the deaths in the hospitals are registered individual and coded with IC10. And this is possible to access these reports. And this information is also available in the international platforms like WHO, UNICEF, and so on. So it is possible now to automatically provide this data recorded. And we also, through the interoperability layer, we share this information with the Minister of Justice, which will also increase the registration of the civil registration process that is under justice responsibility. So one of the modules that had a lot of impact, individual module, was the electronic integrated disease for surveillance. So this is an image of the process of the campaigns that use a lot, as my colleague will soon speak about. And this module, the surveillance module, allows to follow all the outbreaks that have come to fragile many health systems, not only Mozambique. So we can use as timely disease detection, preparedness, and appropriate response. So Mozambique, because it was committed to have this tool, developed this module with the program in the Ministry of Health, and now it's possible to have a more efficient, let's say, crisis response when you have a cyclone or overflowed or something like that. This is the tool. You have a cholera crisis, so you had COVID. So this was the tool that was enable Mozambique to follow what was happening in the field. So the country started with this digitalization surveillance after the migration of the module basic, but was COVID pandemic that make it more visible. And we could see the potential of the system as a tool. Currently, this module evolved, and we are now looking at the management of many diseases, so many program surveillance data, and this system can provide real-time basis data. So this is an example of what are the modules in the surveillance module. So we have the notification, we have the vaccines, and I'm going to stop here because this is the area that my colleague from the vaccines immunization program is going to take over and dive you in the detail. Amelia, please come.
Bom dia.
Good morning.
Bom dia.
Good morning.
Obrigada. Meu nome é Amélia. Trabalho no programa alargado de vacinação em Moçambique.
I'm Amelia Dupufi. I'm working at the expanded program of immunization in Mozambique.
A minha apresentação vai ser em português, porque não quero apenas partilhar a experiência de Moçambique no uso do DHIS2 nas campanhas, mas também quero partilhar o português com quem não sabe falar português.
So my presentation will be in Portuguese, not only because I want to say something about Mozambique, but I want also you to learn Portuguese.
No dia de ontem, tivemos uma sessão com os países lusófonos e eu falei que Moçambique é um país muito bonito, gostamos de pessoas bonitas, tem uma diversidade cultural muito grande, tem uma boa gastronomia e quem está interessado pode vir lá nos visitar e trazer boas práticas.
So yesterday we had a presentation with a track on Lusophony. So I said that Mozambique is a beautiful country with beautiful people. We have a nice food, and we invite you to come to visit Mozambique
Ok.
and to share good practice as well.
Obrigada. Nós adotamos o DHIS2 para apoiar o país na gestão de dados das campanhas. O Moçambique é muito bonito, mas infelizmente tem passado por situações de surtos de doenças que são preveníveis pela vacinação.
Mozambique, we adopted DHIS in Mozambique in order to manage the outbreak and all the health information system, but unfortunately the country has been kind of struggle with outbreak and disease and all these things. Yeah.
Quando da Covid, era uma emergência para todo mundo e tivemos necessidade de adotar o DHIS, porque estávamos a produzir muita informação, tínhamos muitos dados, e não seria suficiente usar o papel para fazer a monitoria e a gestão de tanto dado que estava a ser produzido.
During COVID, it was really very difficult because we've been using paper systems, and we were kind of gathering lots of data, and there was a need to really use electronic systems.
Nós já temos o SISMA, que é a plataforma oficial para a gestão de dados, e no SISMA foi criado um subsistema para a gestão de dados das campanhas.
We already has a SISMA, which stands for Health Information System for Monitoring and Evaluation. But then during the COVID, subsystem was developed in order to deal with the outbreaks. Yeah.
Toda a informação das campanhas de vacinação, nós realizamos a campanha de vacinação do Covid de forma faseada, e todos os dados eram geridos no DHIS2.
Yeah, we used to collect data from all the immunization program, and the data was collected to DHIS subsystem that was developed for that specific needs.
Essa plataforma permitiu-nos ter dados de forma atempada.
This tool allow us to get data on time.
E com o mínimo de qualidade que a gente pretendia ter naquela altura de muita correria.
With a minimum quality that was needed during that kind of difficult time.
Além do registro e da gestão dos dados no DHIS2, usamos também essa plataforma para a produção dos certificados de vacinação, que era um requisito mandatório no caso de viagens ou de comprovação que a pessoa realmente tomou a vacina de Covid.
We also use this tool not only to collect data, but also to issue the certificates, because during this time, this certificate was needed for traveling, for example.
Usávamos também, essa plataforma ajudava-nos sim a monitorar quantos certificados eram produzidos, onde é que eram produzidos, por mês, por dia, e continuamos a reproduzir certificados para quem precisa, e temos essa plataforma para monitorar essa atividade.
The subsystem also help us to monitoring how many certificates were issued per day, per week, per month, where did this certificate were issued in the country. And that was really useful tool during that time.
E logo depois da Covid, ou ainda no meio da Covid, começamos a notificar casos da polio, e quando isso acontece, precisamos responder imediatamente, e a resposta foi campanha de vacinação.
During COVID, we also had notification with polio cases. When you have a polio cases, you have to really deal with that. We have to stop and deal with polio. So then we start really to be engaged in the immunization campaign.
O plano inicial era para realizar 3 rondas de campanhas de vacinação contra a polio, mas com a vigilância e buscas ativas, intensificação da vigilância epidemiológica, fomos notificando cada vez mais casos de polio e tivemos a necessidade de alargar cada vez mais o número de rondas de campanhas da polio.
The plan was to have three phases of the campaign, but during the period we had many cases, so we need to extend it, the epidemiological kind of surveillance in order to deal with the many cases that were there appear during that time.
Como já falei antes, a dificuldade que nós tínhamos na polio era a mesma que tínhamos na COVID, muitos dados, muitas comunidades, e o dado era feito no papel e passava de papel em papel a todos os níveis, e isso dificultava muito o nosso trabalho.
As I said previously, during COVID, we had many cases with COVID, but also we had many cases with polio. And we were using a lot of papers for polio, and then it was very difficult really to deal with this situation with many kind of lots of data, but using paper systems.
E mais uma vez, em coordenação com a DHIS2, que é o nosso parceiro no Ministério de Saúde, nessa plataforma do DHIS2, houve necessidade sim de abrir-se um espaço no SISMA para a introdução de dados de diferentes rondas da polio.
So during this time, with the partnership with DHIS2, who is our main partner in developing these information systems for health, then there was a space to develop these subsystems for polio, immunization, sorry.
Foi desenhada uma plataforma muito simples, mas tão simples que era mesmo da capacidade da gestão do nível mais baixo, do nível da comunidade. Então, a comunidade, o supervisor da equipe na comunidade, depois da vacinação, já fazia o registro num instrumento móvel, como telefone e tablet, dos dados de vacinação na comunidade, e dessa forma já tinha essa informação imediata nos níveis subsequentes.
That was so very easy. I mean, the application that the subsystem that was developed was so easy and very clear for even for the lower level of community, that they can collect data, and as soon as they were entering data at the community level, that data was accessed to the higher level of the ministry.
Esse é o exemplo de alguns dashboards que a gente produzia.
There's an example of dashboard that we produced.
No nível provincial e no nível central ao mesmo tempo. Então, a informação era introduzida na comunidade, o nível distrital, provincial e central já poderiam baixar os dados a tempo real.
This is an example of dashboard that were produced. The data was introduced at the lower level of the community, at the provincial and the higher level of the ministry. They could access in real time the information that we needed.
A plataforma do DHIS2 é uma plataforma que estamos satisfeitos, contudo, ainda tem algumas lacunas. Moçambique tem comunidades extremamente distantes, isoladas, tem locais que não têm rede móvel, e usando essas plataformas, em algum momento perdemos alguma informação que gostaríamos de ter nesse momento. Então, é um processo que precisamos de melhorar, mas estamos a apostar nessas plataformas pelas vantagens que temos visto.
the DHIS, it's a very useful and very good system, but because the country is really widespread, so in some cases in some community we don't access to all data, and we need really to improve, because not always we have access to some of the data in very kind of distant places.
Estamos neste momento a querer mesmo migrar no programa alargado de vacinação do papel para o digital. E queremos implementar o registro eletrônico infantil lá da unidade sanitária e da brigada móvel, pensando nós que dessa forma vamos melhorar cada vez mais a qualidade de dados que é reportada e vamos melhorar o acesso e a visibilidade dessa informação que nós queremos. A Saudígito e outros parceiros que apoiam o programa, já estamos a trabalhar nisso e com muita expectativa que esse processo avance o quanto antes e termos essa informação no tempo real e melhorarmos, claro, a qualidade de vida dos trabalhadores e das pessoas que vão receber a vacinação.
So this was long, was very long, I think you understand. So what she's saying is that we really need to move in order to implement fully the DHIS, the platform to collect data for complete immunization. Also to involve all different kind of subsystems that exist in the immunization to DHIS, because this is we have really access to the most important data, and then we can have kind of a decision on that program.
E com isto, quero agradecer pelo convite e espero que tenham aprendido bocadinho de português que quis partilhar convosco. Obrigada.
So I want to thank you very much for this opportunity that I was given, and also I reinforce that you have to really learn Portuguese.
Thank you, Amelia, for the Portuguese lesson. So, as Amelia said, the current challenge for many of the health programs is to be able to cover the community levels, the areas where we don't have health facilities near. So, the next module I'm going to talk about is the module of Community Health Information System. That is something that is already been in the country, but in the very confined, let's say, program. So the Community Health Information System allows community health workers to manage patient information and the health data, and to monitor what are the health trends over time. So the implementation of a community health information system was key to ensure provision of primary health care, reduce the fragmentation of the community platforms that are already in place in the country, and create an integrated community health information. So, like I said, we already have experience with the lepers program. You can see in the right was a program that we've been using this registration collection from the past years, but with the new, and here you can see some of the information that we already are collecting in lepra. You can see the number of cases in the last 3 months, 3 quarters, and you can see where are the areas in the country that are more endemic or have many cases, and you can follow where you need to focus your supervision and the healthcare support. So now we have a new strategy for community health subsystem. And this resident strategy has a pillar with a very clear objective that is establishing a health information surveillance system and monitoring evaluation the health actions in the communities with a multi-direction flow of information. So this new approach, this new strategy brought a lot of demand to the health information department, because we need to evolve from the leprous data register to cover all other diseases and programs. So the integrated community health information system is based in DHIS2, has been tested and includes the digitalization of all the package of the community agents and provides continuous follow-up on the individuals at the household level. These are one of the modules that the system has. You can see it allows you to follow TB, malaria, HIV, allows you to do prevention and promotion in the community, allows you to registration the births and the deaths, allows you to make a census of the household members. So, and these are the collection, how it goes, and also allows you to receive some notifications about the follow-up that the health community workers need to do in a daily basis. So, like I said, it's an integrated community health information system. So all the programs are present and related, including malaria, that is going to now explain us more in detail how this can be very impactful in our healthcare system. Now I invite Mariana.
Bon dia. Thank you for the opportunity. I will try to speak in English, so be patient. But I know I have backup with Dr. Emilio. My name is Mariana da Silva, and I work for malaria program in Mozambique. In the next few minutes, I'm going to present a summarized programmatic view around the development of an integrated malaria information storage system in Mozambique. This is a bit of context. So in 2016, a malaria surveillance assessment was conducted and noted major challenge with the data management, which includes multiple sources of data with different definitions. As you can see on my right, we have this picture with the Excel data coming from entomology, bednets, IRS, and we also have commodities data. We have the AP information coming through the HMIS, and we have supervision data, and we have data quality checks data. So because of these multiple different definitions, no standardization in terms of reporting tools and indicators, we noted that we have a poor accessibility in terms of integration of all of this data. And also we have no automated outputs. So through the technical working group, there is a decision to make and to define one place where we can find all the stakeholders can find all the malaria information in the same platform. As I said, in terms of solution, a malaria data repository was created based on DHIS2, and it was developed in accordance of WHO repository guidelines. So this malaria repository integrated all the information system that was in place, which we call SISMA, with the AP data and the LMIS data, which allows for different electronic reporting activities not relevant for the system, and creation of new forms to capture all this information, such as entomology, vector control, integrated supervision, and also to include information related to the finance. And also this malaria repository provide automated dashboards, and to set it in place, we trained about 800 users all over the country at the central, provincial, district, and health facility level. We provide all these users with the tablets and airtime in the monthly basis to ensure that they can conduct their activities and they can report all this information on this malaria repository platform. So in terms of the impact that we have with all this data accommodate in the same platform, we saw some improvements in terms of data completeness through the validation that was created in the platform, more specific for supervision, integrated supervision, and ENTO data and IRS data. We saw through this platform improvements in terms of data submission times, where they can use the own tablets and submit information from the health facility and districts. Because we gathering all this information in the same repository, it is now very simple to integrate all these data collections and to do the complexes analysis that was difficult before this repository was set. And we have this time consuming, considering that the data was collected through different instruments. As you can see in this picture, we have, excuse me, we have dashboards with the RDTs where it is collected throughout patients. We have information coming from the LMIS with the consumption of ACTs. We have even information about the stocks on the warehouse. So now we can rapidly do this evaluation, and it is available for all the users. We also, as I said previous, we also create dashboards specific for financial tracking. And this was specific for global fund commodities and non-commodities. And quarterly, we collect information coming for different partners' contribution. And this is one way to involve all the stakeholders and to at least to have this finance information that, you know, it's sometimes very sensitive to have and to the available in the program. So as a next steps, as I said, this is some examples that I brought here, but we have about 25 dashboards with all this information. So as the next steps, we are working in terms of define the data use for district levels and health facility levels. And I was very excited on yesterday on some sessions with the big data extraction. I think there is a good opportunity for us to combine all these tools and to maximize the data use that we know we have a lot on this malaria repository. So this is all that I wanted to share with you. Thank you.
Okay, again, me. So like Mariana said, it's very important to have integrated information and have all the modules integrated in the same platform. That's why we're going to present what is the actual overview of the health information system in the Ministry of Health. So we can see we have the aggregated module, DHIS2 in the middle, and we have all the modules that were developed, the hospital community health system, the malaria repository that Mariana spoke, the surveillance, and all these are connected and in the same integration. They integrate information, and we can come with a common dashboard. But there are also systems from other parts, like the Ministry of Justice, that have a interoperability with the intra-hospitaler. There are the logistic information system that are also integrating now with the aggregated and allows us to have the products consumption for the different programs and to follow up what are the quantification and the distribution of these drugs related with the programmatic interventions. And we also have the human resources that it's now at the moment not very operational, but the layer is there. They are now doing some updates, but is also a current process. So this is the overview, the integration. And we are still working on to improve this integration and with the various subsystems, and an interoperability platform was implemented with the advantage of changing the data analysis, elimination the data duplication and redundancy, improve the set accessibility, enhance the data quality, facilitates collaboration and information sharing, and also allows us to scalability and feasibility. So there is a link there. If you want to copy and see, you can see that we are really bringing in this platform integration information. Here, all the modules that I spoke about in the previous slide, we can see that are through this layer coming with the DHIS2 aggregation, and we can see all the disaggregated information there according with what you need. So we still have challenges, of course, and some of these are related with the infrastructures, the hosting, the internet, the equipment, human resource training, and the skills also in the IT development and so on. We have also to face the emergent tools and platforms that sometimes are not well coordinated with the MOH. We have some policies that we need to update. And also we continue to coordinate all the investments that are available for age management information systems. In terms of perspectives, we would like to continue to improve the data quality, improve the interoperability with the justice for birth registration data, establish a medical record system that is very new. Like I said in the beginning, HIV is one of the programs that is now demanding to have a specific tracking module for the patients. And also there is need to see what is happening with all the patients that come in the health facilities, not only with HIV, but the others, how you can follow up and also bring them to the health information system with the funding that to see the weight they have in the public sector. So this is going to demand a lot of work from our side. We need to expand the community health information systems, the integrated one that I spoke previous, and of course we need to improve the users support through a help desk system. It's a project that we started to talk about because we have a very big country. People are dispersed, and we need to have a support, a friendly support to provide them. So data use, we would like to bring the data from this repository, the integration platform, and with the interoperability layer expansion, we are going to be able to promote the data democratization. What we want now is to be able to share all this information that we came through up to now, over 10 years. We have a lot of information, many programs. It's now the time to share it and to see, because if you don't use the information, you don't improve it. So now the next phase, the next challenge is really to share this information, and all the stakeholders, all the programs, all the managers can see it, can advise us if we are bringing the right information, or there are need of other information. So we come with a closer collaboration. Another perspective is in the governance. We need to lead the process of planning and financing. It's one of the key lessons we have from all this process implementing the DHIS2. We need to invest more resources in the capacity building at all levels. We have a decentralized system now in terms of administrative in the country. So district, province, and central are different. So we need to bring all of them together. We need to continue to improve the data center and build the redundancies to secure the information that we have. And here there is a play with other public institutions that also come to help the Minister of Health. We need to continue to develop, improve, and promote the standards, the policies, and the strategies to be aligned. Everyone that works in the health information system should obey, follow the same rules. And this is one of the weaknesses, because I spoke previously in the challenge, but we are in the way of approving 2 policies and the strategic plan for health information system for the next 5 years. So another is to improve the collaboration coordination among all the stakeholders and partners in the system, of course. So to the technical committees and technical meetings that we need to emphasize and make sure that they happen. This is it. Thank you very much for your attention and for the invitation.
Big thank you to the Mozambican team. We are over schedule, so we don't really have time for questions now, unfortunately. But you know who they are, and we'll have a lot of coffee breaks, and we'll have a social event tomorrow. So if you have questions to the Mozambican team, please reach out to them one-on-one, and I'm sure they will respond. Thank you again. Yeah, so now we need to switch over to the next plenary session on EMIS, and then there's a coffee break that we'll do a little bit later, but probably 10:15. Okay? And then, as you remember, 10:30, we don't have a plenary here, but we will move over to the breakout rooms on the other side. Yes. So while we're setting up, I just want to give you one announcement. So the government of Norway are testing a new emergency alert system today that is mobile phone based. So all your phones, if they're on and on the mobile network, will beep a very, very loud noise for 10 seconds, exactly at noon 12, okay? So if you don't want to listen to this, then you can go to flight mode or switch it off completely. But we'll try. I know we have sessions running up to 12, so we try to cut them a little bit before and maybe move outside, because it will be a very, very loud noise. It's the very first time they do it. Yeah, I can do that too. Yeah. So as you've seen in the agenda, and I think we talked about it on Monday, we have a social event tomorrow afternoon, immediately after the last session here, that ends at 3 o'clock. We'll walk together to the metro and take the train up to the lake at Sognsvann. Okay? So there's no time to go back to the hotel and the Airbnbs, etc. So please, you know, we will, I think, all accept a bit more casual clothing tomorrow. Light, it will be quite hot up there. And there's an opportunity to swim, to play football, volleyball, and enjoy the beautiful setting around the lake at Sognsvann. Okay, thank you.
Okay, perfect.
Do you need one of these or no?
No, I don't think so.
but I'm short, so we'll do it like this. Hello, everyone. It's an absolute pleasure to be here. My name is Sophia Koziakis. I'm the EMIS project manager, so EMIS standing for Education Management Information Systems. I'm just one person in a beautiful team of people who are looking into the education sector, trying to learn what we can from the health sector while keeping our eyes very wide open about the unique intricacies of how children and youth are learning in schools and beyond. So that's the reason why I wanted to put this picture up for us before we kick off our session, just to remind ourselves that for the majority of children, adolescents, and youth across the world, the journey to reach to the top, to lead a life that you have reason to value, whatever that might mean for you as an individual and where you live, is not an easy journey. It's a big uphill climb. And for many, many children and youth, one small drop, one small blip can mean that they will never come back to school. And even though we have been working for many years to ensure we have children in seats in classrooms, we are now learning that they are not learning. So by the age of 10, we have many, many, many learners that aren't able to read and understand a simple text. So it's just a reminder to us of why we're doing this, why DHIS2 is exploring. And when I say DHIS2 for education, and we really should say DHIS2 and the HISP network for education, because it takes a village. So a very brief glance. I'm not going to spend too much time here because you'll get the slides, because we have a beautiful lineup of folks who are going to be speaking today. But just to give you a snapshot of the 6 partner countries we currently are working with. We have gone national scale with tracker and aggregates in the Gambia, many learning still with tracker. We have gone national scale with the Kingdom of Eswatini. We are working in Togo, Uganda, and Mozambique, as well as Sri Lanka, with much, much growing interest, which Christine will speak to at the end of this presentation, and we'll go into more detail in our parallel session. So we are looking at finding that key of being able to get data into the hands of the decentralized, that middle tier, decentralized district level, even trying to see if we can go further down to school level, to those head teachers and to their school inspectors. We're trying to understand equity, inclusion, quality through the tracking. We asked yesterday, why are we doing this tracker in health? We're trying to learn from you and think the same. We are very importantly not coming in to replace systems where they work, where capacity has been built over many years. As DHIS2, what I love is that we can come in and we can play nice with existing systems and maybe find a hole that that system cannot fill, where we can maybe complement. We are so lucky to be reusing all the software features of DHIS2, maybe doing a tweak here and there and asking very nicely. We have so much capacity from the HISP network to help us reuse all that skill that is in country. It is in region. Oslo doesn't often fly to our different partner countries. And then very importantly, something that's building beautifully is university collaborations. Our associate professors, our supervisors, etc., and the research team are really working hard at this. So are the HISP groups. And we have a beautiful team of amazing PhD and master students. So I'm proud. I want to pass it over to a very wonderful person, Sidi Jallo. He is in the EMIS team at the Ministry of Education in the Gambia, and he's also a PhD candidate. So we are really lucky to have you here in Oslo, Sidi. Welcome.
Okay, so thank you very much, Sophia, for the introduction. As you could realize, this should be a piece of cake for me as an educationist and also as a researcher on EMIS. But this is one of the hardest presentations for me to make, because standing in front of health and convincing them that education needs a share of the funding is not exactly easy, but that's exactly what I'm coming to do. So, but let's start by imagine if, as health officers, as stakeholders in our various disciplines, if the education level of, the population that we are dealing with is a little bit, increased. So how easier it would be for us, when we are dealing with them, I assume it's going to be a lot less time spent with them, because there's a little bit of, there's actually a lot of research that has gone into linking education and with a positive correlation with the health of population. So the more educated the population is, the more that they are likely to seek preventive care instead of creative care, if that is the right word to use. So we have also, in terms of last conference and this conference, there's a lot of talk of cross-sectoral linkages and stuff. So we in education itself, there's a lot of possibilities for health and education to collaborate, when the education system is up and running. We have examples where, health, we are using education infrastructure, so education institutions, to conduct vaccine tests and stuff. But in the Gambia, that was during COVID, but in the Gambia, at the moment where I've come from, we have, I'm talking about as recently as last week, we have the Minister of Health itself leveraging education structures to try to get outreach programs to children that are in the communities, to parents that are in the communities. Because in our schools, we have mothers clubs, we have PTA associations, we have all of these associations that are really connected to the schools. So the Minister of Health is leveraging these structures now to try to get to the parents of these children that are in the school. And for this specific program I'm talking about, it's not even trying to look at the population that the education was trying to capture. They were looking at for a vaccination program of the infants that was even out of the population domain of education. So this just shows how, working with the Minister of Health and Education together could be very, very influential. And the target group of education is from 3 years old all the way to 19 years old. And there's a big chunk of the health, target population too, I believe. And the goal of education is to make sure that every child is enrolled, universal education. Every child is enrolled in the school. And I think that's going to centralize most of, the target population of the health in schools. So when it's time for vaccination programs, when it's time for immunization programs, instead of targeting the schools, instead of targeting the community, you can target the schools themselves, where bulk of the population of those vaccination programs are. For example, cervical cancer immunization, for the young adults, especially the girls and stuff. It can be targeted at the schools instead of going to the communities, which is a much more difficult and expensive. So with this, I believe achieving universal education, making sure that every child goes to school is a topic for everyone, including the health personnel. So what education has been, with this importance, has been forgotten for some while. The right to education was specified in 1948, but it was not up till the years leading up to 1990 towards the Juneteenth conference, where most of the education stakeholders were met and sat talking about, we need to start to make this a reality. That was the time that, they started thinking about how are we going to make sure that every child goes to school. Then there was this, education for all network framework, a framework that, tried to make sure that every child is, gets free and compulsory education from the government. And starting from those years, people started to talk about, how are we going to make sure that we plan in terms of policy, in terms of resource distribution, and also we monitor whether we are achieving our targets. That is why, Momentum started to build around this thing that we call EMIS. So in summary, this is one of the most comprehensive definitions we have of EMIS. So it's in terms of usage, is to collect, integrate like most health information systems, and the specific purpose is mostly to support decision making and policy planning and resource distribution and stuff. And the components, as usual, is socio-technical in nature. It has people, technology, models, methods, and all stuff integrated to make sure that it's not only the system of technology that we are talking about. So in terms of qualities, what makes a really good EMIS is it has to be comprehensive in the data that's collecting. It has to be integrated, it has to be reliable, it has to be unambiguous, and it has to be timely, most importantly, because most of our education system at the moment, you collect data at the beginning of the academic year, but it's not ready until the end of the academic year. When it's not useful, then you start the next academic year with data of the previous year. So I don't know how you can make accurate decisions with that. So that's presenting a lot of problems. And some of the key stakeholders in education are the teachers, the parents, and the community in the education. So these are very key. So I mentioned, the communities, I mentioned the PTAs, I mentioned the village development committees who are key in education. So traditionally, education data, talks areas like students, data, teacher data, infrastructure data, facility data, water and sanitation data, resources, finance, and the kind of indicators that we look at, in this traditional EMIS is to look at access indicators, how children are coming into the school. We talk about the intake rates, how many of the, the new ones that are being born are being absorbed into the system. We talk about gross enrollment rates. You talk about, we talk about intake rates also and new entrants into grade ones. Then we talk about, we also have equity indicators that we also measure, the share of girls, that's one, and the parity index across all the other indicators. Then we have input indicators, that is in terms of the resources that the central government, the ministry, and everyone is putting into the education system. So, we have, the teachers that are there, the books that are there, the furniture that is in the schools, and all that are input indicators that are crucial in learning. Then in terms of output, we look at, retention, we look at transition, how our children are moving from one level to another, and, most importantly, completion rate, how much of the students that are coming in are going out, because that's one of are coming out at the other end, because that's one of the biggest measurement of indicators in education. So let's fast forward from, the 1990s, when we had this kind of design for EMIS, and, the thinking around EMIS was mostly this area. But the most of education systems at the moment is configured and are still thinking the same way. But the rules have changed, and, the game have changed, because we are now presented with many problems that, that we need to shift somehow to try to address, because in many of our countries, including Gambia, I'm using the Gambia because one is that's where I come from, obviously, but two, because on average most of our indicators are average in compared to other regions in the sub region. So we have established schools everywhere. So we have a policy that says 2 kilometers for every lower basic school in the country. So, and we have done that since in the 90s, and we have monitored that, and we have made sure that there are schools everywhere. But as a result, we have our GR is more than 100%. That means technically we have created space for every child that needs to be in the school at the LB level. But our net enrollment rate, that is the actual population that should be in school, is only 80%. That means 1 out of 5 that we need to target are not in school at the moment. And how can we find them? This existing system cannot let us know, because we need to individually identify them. We need to know where they are, why are they not going to school, then we can bring them on board. And at the end of the policy period from 2000 to 2015 coincided with the MDGs. The MDGs also was pushing its weight behind, trying to improve access. Now in its report, it has shared with us that even though we have created all the schools, but there were challenges in terms of, the distribution. In many of the girls, for instance, are suffering more from, the dropout. Dropout is affecting more of the girls than the rest. And then we have, the teacher supply in terms of the rural and upper distribution. Teachers are mostly concentrated in lower and not in the upper section. And then we have and the special needs that are mostly left out in planning. And these are people that we really need to focus on. So to drive this, we need to make sure that we look at another kind of EMIS that can help us answer this question, help us solve these questions. And that is why, we are looking to move away from the MGG team of access to the SDGs teams of learning, to collect demographic data, to collect assessment data, to look for data, not just to collect it, but for practice and action to look instead of the centralized approach of collecting data from policy monitoring and planning. Now we should use this approach where data is used to make sure we stop the children that are dropping out and improve attendance and performance. And for this, we need to go down to individual data and to make sure that data is used more on a routine nature. So, but as this, one of the biggest challenges in doing this is EMIS as a whole lacks what we call turnkey systems that can help us do this. Most of our systems are standalone. They don't integrate, they are not flexible, and you've seen examples on that. And there's limited research as a whole in terms of EMIS. But that is why we are in the DHIS2 here today. So my colleague would, talk about exactly what opportunities the DHIS2 has presented us in education. So thank you very much.
Thank you very much, CD. My name is Monica Amuha. I'm a PhD student still researching about EMIS. And so like CD has said, I think we are really learning, trying to learn from health, what has happened, what has been implemented in the health sector, and what lessons can we learn from there to adopt into education, implementation of DHIS2 for education. So as we look at the move from the MDG goals, which were all about having children access school, we are now focused on what is the quality, what is the learning outcome in the SDG goals. So I'll just give a brief country highlights, snapshots of the learnings that we've had, and also the different implementations that are ongoing in the different countries that Sophia had highlighted. And this basically brings out the different contexts in these countries and trying to really understand the context of the country and see how best you can support them to address their needs. Yeah, so one of the key things that we are talking about, CD ended with the need for decentralizing data. Previously, of course, EMIS has been centralized at national level, but even when it's centralized, there's been limited use. So we've really focused on decentralizing data use. And of course, this is the beauty of DHIS2, that it can be accessed at all levels, both central and sub-national levels. So for example, in Uganda, where we are piloting the use of DHIS2 as an EMIS, we've seen that in the districts where we've implemented with the district education managers and all the planners within the districts really have been empowered to use the data. Previously, they were just conduits of this data from schools, and they would just endorse the data, it goes to the center. But now with the DHIS2, they can access their data, and they're using that data really to inform their routine plans, allocation of resources such as, redistribution of teachers, and also advocacy for additional funds from the partners. And then the other thing, of course, has been that EMIS traditionally has been capturing more or less aggregate data, and which has been mostly administrative data. But then we have other data that is from other systems, such as the examination data, population statistics, to enable us to calculate some of the indicators that CD talked about, such as gross enrollment, net enrollment. And then, of course, with the DHIS2, we're able to integrate, to have this data integrated into the DHIS2. So we have examination data, and we are able to calculate the pass index, the performance of these learners based on the data that we have imported into the system. And then the other thing, of course, the capability of DHIS2 is being able to share data or exchange data with other existing systems. And in Uganda, we have the EIDSR that is really working in the health sector, doing monitoring surveillance in the health sector. So during COVID, we're able to have a surveillance module within our DHIS for EMIS instance and exchange data. And this has really improved the collaboration between health and education. Also, CD talked about the need for routine data. And of course, we saw that previously there have been annual school census that are done, and most of the time they have really been delayed and this data hasn't been used. But we are testing the use of a integrated termly data collection tool. And so data is collected on a termly basis. And so you have more frequent data that the planners at the district level and even at the ministry level can use, especially to allocate things like capitation grants that really have to be allocated on a termly basis. Then in the network within the global level, we are trying to see what can we learn and how can we build a standard metadata package for EMIS. Of course, EMIS, most of the time, what we realize is that we don't have adequate package where countries can either use to implement or adopt when they are taking on the DHIS2 for education. So we are trying to understand what are the indicators, how are they presented, and so come up with a standard toolkit and implementation guidance for adoption. Then moving on to the individual level data, and which is really a move in the SDG 4 goal, really how can we achieve lifelong learning? We are seeing that in the Gambia, we have moved into individual tracking of the learners. So we are able to follow these learners along their continuum of education, well, from the time they start up to the time they complete, and see what are the key issues with these learners, why aren't they learning, or what are which learners are dropping out or being absent from school. So all these really help us address the learning challenge that is currently being faced in most education, in the education sector. Then when we talk about, we are also piloting the use of a learner and teacher attendance. And learner and teacher attendance, this is still in the Gambia and also in Mozambique, where we are able to track learners, attendance of these learners. And this is really one of the key indicators of, it's an early warning sign for school dropout. So we are able to do that. And also in Eswatini still, they are still both tracking individual learners and also teachers. So we need to know how many teachers are available, how many learners are available to inform really the education sector planning. So still, just to add more on the cross-sectoral synergies, we are seeing the need for collaboration between education and also other sectors. And here we are getting very good learnings from the collaborational synergies with health. I earlier talked about linkage of data between the education system and the health EIDSR system. But during the COVID-19 outbreak, we are able to configure a dashboard in Uganda to configure the system to capture school surveillance data. Of course, most of the surveillance in health has been in the community at the health facilities. But now in schools, we're able to report how many learners have had symptoms related to COVID, and all this data was available, and we would see which schools were major hotspots and then relay also that data to the health system and have a response team go to schools to support the response to the COVID. Also, we have been able to use, because schools are some of the vaccination sites, so we're able to see, to generate, to get enrollment data from the system and also inform the vaccination campaigns. And this was really working in close collaboration with the health sector. Then in Uganda, I think last year in September, we had an Ebola outbreak. So still we're able to configure the system and see how can we add tracking of Ebola. And so we noted that some of the schools were really hotspots for Ebola. So the response team was really got this information and really responded to it. And also during COVID, we had, we did a national data call quickly in had data imported into the system, and we're able to see a country snapshot of what is our enrollment, how many teachers do we have. And with that, we're able to inform reopening of schools. As you know, Uganda was the last, I think, the country that closed schools the longest in the world, I think. And then we've had various collaborations with partners and with, for example, World Food Program. We are trying to see how can we pilot implementation of school feeding, monitoring of school feeding in schools. And this is in a region that is really hunger stricken. So those are some of the key learnings. And then, of course, we have still, given the education context, we are trying to see what are the other innovations we can build on top of DHIS2. I talked about the learner and teacher attendance tracking, and this is these are applications that have been developed on top of the DHIS2 and trying to pilot them and understand how can we track monitor individual learner and teacher attendance. And then also, of course, have these apps beyond just tracking the learner or the teacher. Can we see that these apps are very user-friendly? They are using SMS-based. We are testing that in the Gambia, where we have the SMS app. So it's at no cost to the teacher. So this is within a closed user group, and the teacher can send the number of learners that are present or absent, or teachers that are present or absent on a given day within a given shift. So that really helps to inform still on that attendance monitoring indicator. Then also to ensure that we give feedback to schools and also to the communities, we are trying to design a school report cards that are in an easy to understand format for the school and easy to interpret. And these school report cards are it's an application still that we've developed in the DHIS2 and will be used now to give feedback to the schools and more so to the communities, engaging the parents, the teachers, some of the communities and the parents in the communities, some of whom may not be at the same level of understanding to interpret these usual indicators. Then in Sri Lanka, they are going, of course, like in Sri Lanka, what they are doing, they are going a separate model. They've started with the capacity building of all the ministry staff, the Ministry of Education staff. So they want to own the system and move at their own pace. But now they're using it, they've used it to carry out a national teacher assessment to assess how many teachers are within the national system, and then from there it's going to inform the next implementation. So more of this will be presented, I think, during the DHIS2 conference and academy that is going to happen in Uganda, and we shall share more on that in the parallel session. So lastly, of course, like Sophia said, we are looking at integrations. How can we integrate with existing systems? And we are having a use case in Togo and Mozambique, where we are integrating DHIS2 with StatEduc and also with existing data such as mixed ego data. This is survey data for really to allow cross analysis with administrative data. So these are all the learnings that we've had in the different countries, and we shall be sharing more in the parallel session. Thank you.
Thank you so much, Monica. And as mentioned, we have the parallel session at 10:30, but we also have an expert lounge at 5 o'clock with some of the developers that are working on EMIS applications and the integration work. So please do come have a chat. I'd like to give a very, very warm welcome to two colleagues from the Ministry of Education in Togo. We need to thank you so much for taking the time out of a very busy schedule to come join us and be part of the wonderful DHIS2 the DHIS2 Annual Conference. So we really appreciate you being here, and maybe we can give them a round of applause for coming with us. Thank you. I'd like to call on Mr. Kosi Tsali to give a presentation, and I think we have Kofi who will be helping us with translation. Thank you very much, sir. Merci.
Would you like me to move for you?
Am I doing it in English? Or maybe,
Up to you.
okay. Let's say in English. Okay, good morning, everybody. I'm not Charlie Corsi. Charlie Corsi is the head of office of planning statistic and let's say I want assessment. Yes, assessment department office. So he's one of the head of office. I'm in charge of statistics in that office, and I have the pleasure to present what we are doing in Togo with DHIS2. So my presentation will be on 3 parts. Kofi wanted me to try it in English. That's what I'm because we thought to make the presentation in French, so he will interpret, but as I'm coming here, I have the inspiration to do it in English so that you will. Okay, we will speak about what we did, that is what we were doing, what we are doing now, and what we intend to do. So the background, what we did or we were doing, that's the evolution of production education data. We did it manual, mechanically, and then we have introduced some applications such as AP Info, AP Data, and also CS Pro. But in order to have a reliable and complete data produced quickly, we made the choice to go to StatEduc. That is an application developed by UNESCO technicians to help member countries access data on the longitudinal plan with MS access backgrounds. So that helps us to data entry, processing, and use with that's our application that is available, because we have the many versions of StatEduc 2. Then after the collecting of data, and we export that data from StatEduc to SS to make some manipulation, and we produce also dashboards into Excel with the data we have collected into with the StatEduc. But in 2021, we have made a diagnosis of the statistical information system that shows that we need to go towards an EMIS so as to have an integrated aspect of data use and also analysis, even at the decentralized level. So what then are the objectives? Just to have real-time reliable data on the variety of topics in a single database or warehouse data. That will help us also to improve and ensure holistic management of the education system, and then to help us to make decisions in political education so as to how to improve things. And then the Ministry of Education have now signed a collaboration frame with, let's say, with DHIS2 WCA in Togo to help us. So, a technical team it has been put in place, composing various stakeholders within our Ministry of Education. And then they have been built up in their capacities to how to configure the DHIS2 with what we want to do. And then also in the process, we have collaboration with UNICEF, since we are producing already, let's say we are in the project of Data Must Speak with UNICEF. And also we have participated in Miss Eagle. that is to use some data in the mix to make research and to how to improve the things. And all those things are made by the financement of NORAD and KISS IDLC. And what we have done together, and we have an integrated EMIS platform encompassing geocos, administrative boundary, and school contact details. We have data on infrastructure, learners, teachers, examinations. We have also the data of NIS survey that are, I say, integrated within the DHIS2. We have a team, I've also already said it, that we have a team that has been strengthened, a national team, and we have also built up the capacity of some inspectors of primary and secondary school in the pilot zone that will help us. That is, we want everybody now to go to use the data they are collecting so as to improve the quality of this data. Because since if they do not use what they are collecting, they cannot know the problems, the various problems around it. And it's being done with DHIS2. And here we have strategic, we have made an interoperability with, that is our application that we are using, strategic. We have made an interoperability with DHIS2. And if that's here, we are, let's say, some screens of strategic 2. And that interoperability help us to have those graphs that is within DHIS2. So the data have been taken from strategic 2, integrated into DHIS2 that help us to produce that graphs. This is the data from mixed eagles that also have been integrated into DHIS2. This graph makes us to make some comparisons within the data we have collected and then what the survey has been produced. We have here some, let's say, the achievement rates of that have been calculated with our data, and then what Mixed Eagle has brought out. Yes. So with DHIS2, we are developing some illustrative dashboards. That's one of our projects we want to do with DHIS2. So we have here a photograph of the national team building capacity. The national team of 16 actors. And then there we have configured with the team of, let's say, DHIS2, and their capacity have been built on the interoperability with strategy. This can go on. Here is the piloting zone. That is this project of helping the actors, local actors, to use this data. That's the project, but the pilot zone is our, let's say, region, maritime, that's in south in Togo, to how to use the data so as to improve his quality. So it is the session of training. So those people has participated, that is the photograph. So what is the next step? The next step is to complete implementation of pilot phase, use of data at local level, and implementation of an electronic school observation system. And we want to scale up to 81 inspections and 7 regions, and assure the interoperability with examination management application, because we have many applications that are help to manage many themes, many areas of our education. And then we have also a project of a school ID cards. So DHIS2 will help us to do it. And also this will be based on the unique student identification system. That is another project we have started. So we expect that DHIS2 will help us within our collaboration. And I think that is all.
Yes. Yeah, that was it.
So I've tried it. Okay. Thank you.
Thank you.
Thank you. No need of translation of this one. Very good indeed. So I will just be very brief to tell a bit about how the Banjul Academy 1 year ago, 1 year, 3 months ago, actually amplified the initiative of this DHIS2 for education. We were able to meet after 2 years of pandemic. Actually, the academy was planned and we were all having our suitcases when the whole world was locked down in March 2020. So the energy coming from this Banjul Academy, where we spent 5 days together only, it felt more, with having 3 days of strategic discussions with all the actors within the global actors in the field, the regional actors in the field, the 8 Ministry of Education apparent, and the whole Gambia, I would say, all the regions, even the West African Examination Office, everyone that could be having a stake in the DHIS2 for education was there. We spent 3 days, or actually the whole week, with the strategic first conference. Then we divided into 2 with training for most of them, and the rest was making this communique, where we actually made a plan for implementing EMIS data for education, Pan-Africa, but not only for Africa, but a bit focus on Africa, because African Union was very leading here, and ADEA, which is also part of the African Union, where we carved out in details. It looked like the implementation plan for DHIS2, where we carved out in detail how we could work with countries in order to solve the gap of the lack of data in the educational field. And this communique was signed by all these ministries, all these partners, including NORAD, actually. Not often NORAD is signing on those kind of things, but felt the pressure from African Union on all the others, UNESCO, UNICEF and all. And that communique kind of amplified the initiatives throughout the whole Africa and Asia. Next. We'll be seeing a lot of growing interest from countries, and we can see the list here, and more is coming. And we can see many of them, or you have taken it out, which of them, that was actually the Minister of Health that are pushing, because the competition between the education, when education see that the beautiful amount of data and analytical tools that the health have, Minister of Health have, the education want to have the same. And the Minister of Health are the one training in the Ministry of Education. So we can really see the spillover of the capacity in the ministries, in the government, but of course also in the HIS groups and the region. So with very limited amount of money, because there is not much money in the educational sector. However, the government is very, very energetic and eager, and maybe have more money locally in country. So there is a huge opportunity of leveraging on this capacity that we have in the countries to show how we can actually utilize the tools, the capacity in order to support the Ministry of Education in achieving the SDGs for better education for all. I will end there. We'll encourage the ones that want to have more in-depth knowledge about it. We have a parallel session just after the coffee break. And we also have an academy in Kampala, Entebbe actually. to be honest. Sorry for that one. In August. So that's just to run for registration, and we will continue the great work and report next year the new achievements. Thank you.